Barbara McLean is a critical care nurse and has a long history of education in the critical care fields. She'll be talking to us today about hemodynamic monitoring for patients in the ICU.
I'm really happy to be here. I'm so honored to have been invited. I'm actually a critical care clinical nurse specialist, and I work with advancing practice at the Grady Hospital, and I have a lot of my really great colleagues that are here today, and I want to just make sure that everyone appreciates that I'm sharing with you my opinion, not necessarily the opinion of everyone, but my opinion of how you develop a minimal to maximal hemodynamic platform. So as you know, this is a really quick talk, and we'll be able to actually highlight some of this information in the hemodynamic simulation program this afternoon and really explore that and talk more about it. So what we're doing is just having a quick survey of a hemodynamic platform. So one of the things I think is really important for all of us to consider is there really is no one way to evaluate hemodynamics. But I want to be sure that we all appreciate that we're looking at three different things. That we look at stroke volume, we look at tissue perfusion, and we look at compensatory mechanisms. So I think it's really important for us to appreciate and understand there's lots of different methodologies that we can evaluate and use at the bedside, but we need a full platform that really guides us to understanding why we advance technology. So we might start with something non-invasive and laboratory analysis, move to minimally invasive and laboratory analysis, and then move to maximally invasive and laboratory analysis. And that's really what I'm going to cover here today. So I like to always make sure that we appreciate that we look at two things. And I think that we have to have a platform that combines these two. First of all, macro circulation, which is actually about your stroke volume, your vascular tone, your blood flow dynamic. And there's so many ways that we can look at stroke volume. We can look at stroke volume in non-invasive methodologies, arterial-based cardiac output, either calibrated or non-calibrated, whatever it is you're using, PICO, LITCO, FlowTrack, CHEETAH, whatever you're using, all of that is good, and appreciating that you're monitoring stroke volume. When we compare that to the PA catheter, so many of us still use it, and actually we're probably going to see some resurrection of the PA catheter. It's important to remember the PA catheter actually does not monitor stroke volume. It looks at temperature change over time. It monitors cardiac output. Stroke volume is calculated. But with the other methodologies, stroke volume is monitored and cardiac output is calculated. So really important for us to appreciate those differences. And also my favorite thing to remind everyone, because I was there with the first PA catheters placed in human patients. I'm so old. Like my first pet was a Tyrannosaurus Rex. I was there with the first PA catheter and always remembering that originally with the PA catheter, it wasn't named Swan-Ganz. It really isn't named Swan-Ganz, that's a brand name. But with the original PA catheter, we always called it a right heart catheter, and I want you to remember, it's a right heart catheter. You don't need a PA catheter to really tell you about the left heart. You need a PA catheter to tell you about the right heart. So that's macro circulation, and then we combine that with microcirculation. And no matter where you work, you have the ability to look at microcirculatory evaluation. You can use base deficit, you can use partial pressure of venous minus arterial CO2 to tell you about blood flow dynamics and tissue production of acid at the cellular level. But a lot of our focus really today is not really evaluating bicarb, but looking at your base deficit and correlating that base deficit to some methodology. So we certainly know that there's been huge amounts of controversy about using filling pressure to correlate to volume. Well, honestly, if we understand hemodynamics, that's not a big surprise to us because pressure is volume over change in compliance. So we have somebody who's tachycardic, we have tentative PEEP, they're on airway pressure release ventilation, they're on oscillation. You're going to change the compliance of the heart. Filling pressure measures go up, but the patient may actually be relatively hypovolemic. So that's really important for us to appreciate. So in all of the concurrent literature that we're looking at now that actually guides us to appreciate, filling pressure is not volume. Okay, but that's okay. We can still use the filling pressure and correlate it to our left heart ejection to guide us in therapeutic evaluation. And most of us are doing that today. That's a basic Frank-Starling curve. But we know that this is not the way we should be measuring volume by filling pressures. So that's really important. There's so much literature, and you'll see that every once in a while I put a little a little subset here, which is in your handout, about reading more about it and really reminding yourself that both CVP, wedge pressure, and PAD are profoundly affected by alterations in pulmonary compliance. So I want to make sure you appreciate what I've just said, which is not that you've admitted somebody with known chronic pulmonary hypertension, but that you've admitted somebody, intubated them, put them on positive pressure ventilation, and are using mean airway pressure strategies to actually recruit the lung, and what that burden it puts upon the heart. And that's when all of your filling pressure signs and actually your LV filling and your LV ejection are going to be altered in relationship to that change in pulmonary dynamics. So I like to start off first reminding you that anything that you're measuring in the artery or in the pulse is actually about LV stroke volume. With your PA catheter, remember you're looking at RV ejection, but with the arterial catheter or pulsatile signal, you're looking at LV ejection. If you're using electrodes on the chest, what you're looking at is thoracic volume, which is also fabulous. So I'm not having any preference of what way you look at it. I have a preference that we actually are looking at what the meaning of the information that we're evaluating is and being able to discriminate, to say PA catheter information is not necessarily going to match arterial information. PA catheter information is not going to necessarily correlate to bioreactance or bioimpedance because they're looking at two different things. So really important for us to remember that we are so lucky to be able to evaluate LV ejection and to look at that even with the simple pulsatile pressure on your pulse ox. So that's what you can begin with, and then you expand from there and go further and evaluating LV stroke volume. So one thing I like to remind everyone, we have a great audience, a lot of variety in terms of profession, but really important for everyone to remember. If you can't get a pulse ox on the right hand and you can't get a pulse ox on the left hand, you don't have good perfusion. In general, you just don't have good perfusion. So you spent 20 minutes, right hand, left hand, all the fingers on the right, all the fingers on the left. Now we move to the ear and the lip and the nose and the head. Still can't get a signal. Meanwhile, your patient is hypoperfused because you've got to have perfusion to have a signal. Now, are there other problems? Yes, of course. But it is really important to consider that. So I do want to tell you and remind you that in general, when we look at methodologies to look at LV stroke volume, there is no pure superiority study. That all our methodologies are non-inferior. So comparative analysis has not come to any point to say this is the superior way to look at LV stroke volume. A lot of it depends on what your value analysis has encouraged. It depends on what the comfort level is of our staff and our colleagues and what it is we're using at the bedside, but we don't have one methodology that's superior to another. We love to look at LV-based stroke volume because it gives us good information. And this is what we're resuscitating. We resuscitate stroke volume. So if you have the opportunity to be doing some kind of arterial or thoracic or pulsatile monitoring, remember that cardiac output measure or that cardiac index measure is a calculated measure. What you're really looking at is stroke volume. And you're looking at the pulsatile stroke volume and the beat-to-beat variability, really important. And so we just remember that our normal stroke volume is 60 to 100 mLs per beat, so nice because it kind of correlates with the sinus node rate. But patients can actually increase their stroke volume by increasing myocardial contraction and venoconstriction in order to actually have a compensatory increase in stroke volume. And of course, that's what you see early in sepsis, is your patient early in sepsis, if we catch them early enough, have a compensatory increase in their stroke volume and therefore, of course, their cardiac output. So really important for us to appreciate stroke volume and then, of course, stroke volume index to the body surface area. Always really wonderful. And I always remind you that although you might make LV measures of stroke volume, you always need to correlate that to the delivery of oxygen and the return of carbon dioxide. And I think we forget about the return of carbon dioxide. We're very ventilator focused, and that's gorgeous. But we have to actually remind ourselves that CO2 production at the cellular level actually is heightened or increased when we have patients who have poor blood flow because they have ischemia. So they make more CO2, and now I put a big burden on my ventilatory compensation, my respiratory therapist, the mechanical ventilator, in order to help us blow off CO2 and to do that appropriately. So we always want to remind ourselves that the end point is how is the perfusion at the tissue, how is oxygen delivery at the tissue, and how is the acid production at the tissue. That's really what brings us to microcirculation. So I think anybody who knows or who's following the evidence and putting this into play in their own practice, we talk a lot about how we actually measure whether or not a patient is responsive to volume. So the overarching evidence would say the only way you know if someone is fluid responsive is if you're actually doing a stroke volume measure. You can't really look at volume responsiveness from arterial pressure or CVP. We already know that. We know that evaluation of fluid responsiveness really does require that we have a methodology for stroke volume monitoring. And continuous stroke volume monitoring is the gold standard today. So lots of different methodologies, just a basic comparative analysis, talking about invasive, minimally invasive, maximally invasive. And what we just want to remind ourselves is that in general, everything is good. We have a few things that are fair, but in general, everything that we're using and everything that we're comparing is pretty good, and our methodologies are really going to be based on what we have available to us at our hospital. So I always like to remind everyone that you're administering fluid into the venous circulation. You're not giving fluid into the arterial circulation, you're giving fluid into the venous circulation. You have to be able to fill the right heart and mobilize that fluid through the pulmonary bed. And when there's obstruction, that's my interest, obstruction in the pulmonary bed related to positive pressure ventilation, what you're going to see is a venous volume overload, extravascular volume overload, but LV stroke volume, that's inadequate. So it's always important to compare filling pressure to stroke volume. And that gives you some guidance to actually evaluate whether the fluid you gave the patient actually makes its way into the arterial bed, which is the only place you care about. That's the place you care about. You want that volume in the arterial bed, but you're administering it in the vein. And lots of times you're using venous pressure measures to tell you about fluid responsiveness. Now, I love the good old Frank Starling curve, just to remind us that there are therapeutic interventions are about trying to maximize that stroke volume by our volume resuscitation, our inotropic resuscitation, and really important to remind yourself that vasopressor resuscitation improves the blood pressure but limits the stroke volume at some point. So when we're evaluating patients at the bedside, we're titrating up on vasopressors. Again, we want to look at the effect that has on our stroke volume because you want to meet that sweet spot, just like we talk about with ventilation. You need a sweet spot where I've maintained the patient's driving capillary pressure, their mean arterial pressure, but I have not limited LV ejection. So we have to have a methodology, a method to say, did the volume I give the patient actually make its way into the arterial bed? Does an inotrope support mobilizing that fluid into the arterial bed? And does my vasopressor support or limit perfusion? And not really perfusion, more importantly, LV ejection. Okay, so one of the things we talk a lot about, and of wonderful methodologies, and everybody should make sure they get some time to look at all of our methodologies that are available here today for you to evaluate, talking about giving the patient his own fluid bolus by lifting his legs. Passive leg raise is a very profound way to evaluate volume responsiveness with very significant limitation on secondary problems. Because you're lifting the legs, bolusing the patient with their own fluid, you put the legs back down, and the fluid returns to the legs. So it's without much incidence, without much concern, but it has to be done in a very particular manner. So we can look at lots of different methodologies. We look at thoracic volume shifts, echocardiogram, ultrasound, arterial-based cardiac output, pulsatile cardiac output. All of this information will help us when we're looking at passive leg raise, but you've got to have a methodology for stroke volume evaluation to do a passive leg raise and to do it appropriately. And there are really particular ways to do it. I'm sure most of you already know this, but the way that we talk about doing it now is that we put the patient up 45 degrees for 3 minutes, put him flat with the legs up for 3 minutes, and then return the patient to the head of bed elevation. So it's 45 up and semi-recumbent, then in the supine position with the legs elevated, and then the last visual, which isn't here, is to return them back to their semi-recumbent position. So it's 3 steps, and it really does take about 6 to 8 minutes and a lot of evaluation. So what you expect to see, you always will expect, you hope, to see that when you lift the legs, that actually the stroke volume will go up. But because you also want to evaluate, it's not just because I lifted your legs, stimulated you, did something else. That's why we return patients back to the semi-recumbent position, because then that actually tells us whether or not this was actually a patient who is responding to their self-delivered bolus of 300 to 500 mLs of fluid. Okay, so again, remember macro circulation, so whatever methodology you're looking at to look at stroke volume. Now we're going to combine that to tissue oxygenation, which is microcirculation. Everybody's in love with lactate, despite the fact that there's over 400 causes of an elevation in lactate. We all are in love with lactate, and that's good, because that's moving us forward, and that's perfect. But it is really important to remember that lactate is a dysmetabolism measure. It's worsened in hypoxia, but it's a dysmetabolism measure. So it's perfect to look at lactate as an indicator of dysmetabolism. And again, in early sepsis, early compensated sepsis, typically you see a mild elevation in lactate because the patient has dysmetabolism. But as they progress in hypoxic sepsis, the lactate will go up significantly because now you have dysmetabolism and tissue hypoxia. So we love to look at lactate. There are many reasons that lactate elevates that are not about tissue perfusion. Metformin, antiretrovirals, so many reasons that lactate will elevate because it's a dysmetabolism measure. It goes up when you have diabetic ketoacidosis, and it becomes hard to differentiate what's hypovolemic and what's because of dysmetabolism. So we just want to be intelligent about evaluating this and want to just always remind ourselves that we're going to look at this in conjunction with my favorite, which would be the base excess or deficit. So I just want to remind everybody, I don't want to say anything too simply, but you can see I'm talking fast, that the base is a more pure, even though it's calculated, a more pure indicator of total buffering capability for the production of metabolic acid. So the base excess or base deficit is a very direct link to metabolic acidosis. Remember, when base is in deficit, acid is in excess. When base is in excess, and I'm talking about metabolic acid, when base is in excess, metabolic acid is low. So we want to just apply that because it helps us to actually correlate that to our tissue metabolism. It helps us to correlate the incidence of hypoperfusion. It's also, of course, affected by things like DKA. So we always have to have a clear idea about what we're looking for and how we're going to value that data. But my nursing colleagues who are here know that if they communicate to me and they say, well, the patient's got this, I'll say, well, what's the base? What's the base? Tell me what the base is, because that's the way I'm going to actually be able to help them figure out what they want to talk to their physician colleagues about and what they want to evaluate on the patient. Now, in addition to that is the anion gap. Probably everyone knows anion gap. Everybody's pretty happy with the anion gap, thinking about the relationship of positively charged particles and negatively charged particles. And to remind yourself that the metabolic acid hydrogen ion is a positively charged particle, but you don't measure it. So it's not a visible increase in your positive charged ions, and that hydrogen ion binds to chloride and bicarbonate. So chloride and bicarb go down, and you get a gap. And a gap greater than 20 should be always an indicator of the big four. The big four, what I say at the bedside, not mud piles. I think that's great. Fine. You can memorize that. I just say the big four: ketosis, lactic acidosis, renal failure. And then the fourth is a normal gap with a base deficit, hyperchloremia. And that's, of course, what drives our focus today in volume resuscitation, why most of us are trending away from the administration of sodium chloride because of the incidence of hyperchloremia, which then presents as acidosis, which then triggers that we're going to give more fluid, and we see it get worse and worse and worse because chloride binds to hydrogen, HCl, weak acid. Okay, so just reminding ourselves that we can look at your chemistry profile and we can say, oh, on a venous chemistry, I can see what your anion gap is, and if your gap is greater than 20, I'm in pursuit of why your gap is why, and I'm going to start in the critical care area. I'm going to start with a horse before I go to a zebra. Like, did you ingest methanol? Okay, No, you're probably in ketoacidosis. You might be in lactic acidosis. You can be in acute renal failure. And then that fourth consideration is you've got metabolic acidosis with the normal gap, typically is hyperchloremia. Okay, so this is something I really adore. It had so much evidence, and really lots of folks that are interested in hemodynamics talk a lot about the partial pressure of venous minus arterial carbon dioxide. So you're drawing an arterial gas and venous gas same time, and you're looking at the difference between the CO2. Normally, the difference is at around 5. So if you think about what normal arterial CO2 is, 35 to 45, normal venous CO2 is 40 to 50. But if I have dysmetabolism, I have tissue hypoxia, I'm going to have more production of CO2 at the cellular level, which means, first of all, the reason your patient is tachypnic is because they're blowing off CO2 to compensate for this profound acidosis. And we have to address that also with our ventilators when we intubate our patient. So I just want to remind you how beautiful this is. And then, of course, we can also correlate it to end-tidal CO2, which is beyond the scope of this talk, but I'm happy to answer any questions in regard to that. So I just want to remind you about this production, just to remind you that PA CO2 is around 40, PV CO2 here, 45, 46, that you always expect the venous CO2 to be higher than the arterial CO2 because you're actually producing carbon dioxide in tissue respiration. That's why it's a respiratory acidosis. This is a tissue respiration byproduct, unlike the tissue metabolism byproduct, which is hydrogen ion. Okay, now that brings us to SCVO2, which is our central venous oxyhemoglobin. Lots of data to show us that there's a correlate between the central venous oxygen, or the central venous desaturation of hemoglobin, and the mixed venous desaturation of hemoglobin. But I would just remind you that in a patient who's tachycardic, your central venous oxygen is going to overpredict how well your patient's doing. If your patient's got a heart rate of 130, his mixed venous saturation is going to go down. And the central venous saturation is not going to truly predict what's occurred. But we know we really like that. Okay, so my last 3 slides. Okay, the role of the PA catheter in the ICU. So when I was originally invited to talk, the original idea was, will you talk about what's next after the PA catheter? Well, I can't do that because I really believe there's a role for the PA catheter in the ICU. I think the role for the PA catheter in the ICU is completely different than what we thought historically. The role of the PA catheter is more about looking at right heart evaluation. So, those are the questions. When I started in practice, which was, before half of you were even born, everybody, their brother, their dog, their cat, their uncle, it didn't matter who they were, they all got a PA catheter, okay? So that was in the time when everyone needs it. And today we say nobody needs it. Okay, well, there's something in between. And what we as bedside nurses see, that PA catheters get placed, but no one pays any attention to the data. Okay, but if I'm looking at a person who is in ARDS, who is requiring 5, 10, 15 a PEEP or airway pressure release ventilation, and I have a PA catheter and I see those PA pressures go up, and I see the end-tidal CO2 go down, and I see the venous CO2 go up, that's a perfusion problem. That's not a ventilation problem. I'm not going to address it with the ventilator. I want to address it with perfusion. So I want to remind myself that the PA catheter has a lot of value when used in the right place. Never was, and isn't now a left heart catheter. Even when you inflate the balloon, you're still on the right side of oxygen exchange. It's a right heart catheter. Trying to make it fit for the left heart works beautifully if you've got a patient who is not on a ventilator or somebody who's on a ventilator with very low positive pressure and who has a low PEEP. Then you can use your wedge pressure, your PAD, to predict left heart filling. But it's not about volume. It's about volume and compliance. So very important when we're looking at that. And again, remember that continuous SVO2 tells us about the global use of oxygen, not just cerebral and upper extremity, which is what you're looking at with central venous oxygen. And then, of course, continuous cardiac output, which gives us information over time from the PA catheter. But remember, this is a cardiac output monitor, not a stroke volume monitor. If you were really sick and I was asked for my opinion, I would say, oh, you're really sick. I want you to have a basic methodology for arterial volume evaluation, whatever way I'm going to do that. And I'm going to want, if you're on 10, 12, 15 of PEEP or airway pressure release ventilation or pressure control inverse with prolonged die time, I'm going to want you to have a PA catheter as well. And what I'm going to try to do is manipulate both my ventilator settings, my volume resuscitation, my inotropes, in order to equalize that blood flow dynamic. Because what we traditionally see is if we have a PA catheter and an arterial measure is there's a wide gap between those measures. One is the right heart, the other is the left heart. Probably not going to convince anybody about how important this is, but it is important to me. And then just to remember, SpO2 monitoring. So we kind of bring that all together in a really short format to just say we have static or venous measures, and venous also meaning primarily deoxygenated blood, compared to dynamic or arterial measures, and then compared to tissue or capillary measures. And looking at that all together in terms of perfusion, how we actually can incorporate one, which would always be what we look at the tissue, and then adding a methodology to look at arterial volume resuscitation, and then considering a methodology to look at your deoxygenation and the deoxygenation blood flow. And that's the wide platform. The sicker you are, the more catheters you're going to get. That's what I say. Okay, so my suggestion of a platform is basically start small. Think about using bioimpedance, bioreactance, pulsatile waveform, arterial-based cardiac output. Start small. Correlate that if you have the ability, that you have a CVP. So as your CVP pressure goes up, your stroke volume ought to go up as well. That's a basic Frank-Starling curve. And then move farther into the evaluation with an indicator of microcirculation. And if we are doing aggressive ventilatory management, what we're seeing on chest x-ray, you have a high degree of extravascular lung water because we're seeing that you have infiltrates. Now we're going to consider, do you need a PA catheter to help me maximize right ventricular ejection and right ventricular filling in order to maximize blood flow dynamics? So it's a wide platform. There's no one answer. Read more about it. Thank you so much.